I recently had the very real pleasure to interview Bolivia's leading corneal consultant, Dr. Patricio Lo, who manages a lot of pterygium, and I spoke to him about his surgical technique in managing pterygium in his practice. It's very similar to what we do at the Andean Medical Mission. We have a slightly different approach to the block. We tend to do a peribulbar or retrobulbar block, and we do a corneal stay suture, which he doesn't do. But other than that, it's very similar. There are a number of studies looking at the incidence of pterygia across the globe, and basically if you are running eye camps or eye projects south of the equator, then you're going to come across pterygium as a real problem and a blinding disease. To give you an idea of the incidence of pterygia, you can expect about 30% of your population to have a pterygia if you're working somewhere like Bolivia. So the highest ever recorded incidence of pterygia is in Nepal, I believe, with around about 38% of the population having pterygia. The second highest recorded area is actually in the Amazon, in the Brazilian Amazon, and one village of Aravac had 290 people living in that village, and about 95 of them had a pterygia. So you can expect a lot of pterygia to present in your practices if you're working at a similar latitude to, say, Brazil or Bolivia. Bear in mind that this is very much an environmental disease. Pterygium is as a result undeniably of ultraviolet light, exposure to that light, and people who work in outdoors in dry, dusty conditions without protection from the UV sunlight are going to get a lot more pterygia than others. Those are the people you're going to be operating on. And part of your strategy for reducing blindness is, of course, to provide surgical options to that patient population, but you need to counsel them on making lifestyle changes following the surgery. There's not much point to doing a really good operation and then having another pterygium form because your person still didn't go out and wear a sun hat, didn't wear protective glasses, didn't use lubricants, didn't protect themselves from the force of the sun. People have to work, so it's very probable that they will go back to the same job. And we find agricultural workers, lorry drivers, road construction people are the ones that come in with just these horrendous pterygiums. So you need to counsel those people and explain to them that, you know, it's an environmental disease and they're going to get another one if they continue to live as they are. And so sun hats and sunglasses are incredibly important as part of educating your population. So anyway, without further ado, let's play Patricio's interview, and I hope you enjoy it. I hope you learn something from it. Everyday practice.
Thank you. I'm glad for the interview. The pterygium in this country, in our population, is a very often pathology. We can manage almost 10 or 15 pterygiums a week, more or less.
Right.
I can say mostly it goes well. It goes well with proper education for the patient and when the procedure is well done. I could say that the recurrency of the surgeries we perform is very low right now. I think the pterygium it needs to be taken as soon as possible. For so long, too many colleagues used to think that it will be better to let the pterygium grow I think when it's more grow, that surgery it will be a little bit harder for the patient. No, the post-operative, the risk for recurrency is higher, and the symptomatology. No, so I think that grade 1, grade 2, it could be better, and the result it will be better. First of all, I work with the infiltration of anesthesia. The anesthesia is subconjunctival, and it works, or it helped me a lot, because it's like an hydrodissection of the head of the pterygium. As well to the aesthetic part. So the first thing I perform is to inject anesthesia subconjunctival, directed through the cornea to power up a little bit the head of the pterygium, as well of the place where we're gonna take off the conjunctiva plastia. No, that is gonna help to take off the head of the pterygium. I use the way that is with traction. It's not coated. I use divulsion of the scissor just to pick it up, or to hang it up, the head of the pterygium, and then is for traction. That's the best way to take all the head of the pterygium in the easy way, and not to leave too much rests of the heads on the cornea. And to clean up the cornea, or scrap, there's two ways basically. I like to use a basic bisturi, a knife, a common knife. It's a round head, and I like to clean a lot the cornea and the limbus. I think that if that part is not well cleaned, well shaped, the chances of the recidiva is getting higher. No, there's a drills with diamond flow. I don't know the drills. I use it, but I prefer use the single knife. I have better. As we talked before, I try not to use Pterygium too much, because the vessels working help me to adherency of the plastic, and take off the inflammation. So my surgeries are a little bit wet, a little bit red than others one, no? But I think is better. After removing the head, the next step is cleaning well the limbus and the cornea. I took mostly the time of that surgery cleaning well, and then I do not leave free marks from the pterygium. I only resect or cut the pterygium margins, and then I go through the neck of the pterygium maximum. I took off the head, the neck, and leave the placa of the pterygium. And then I try to make sure to take all the tenon is round the place that used to be the pterygium body. No? I like to take off the tenon capsule mostly that it can. The way that I treat the graft is this way. I already inject some anesthesia before that. It's gonna help to take the graft up and not manipulate too much that zone. And the graft, it tried to be the same size of the resection of the pterygium. That's important, because if you do a smaller graft, it could be get more tired, and the aesthetic result will not be the perfect one. No, so a bigger graft or minimum the same graft. Sometimes I used to mark, but I stopped doing that because of the time. In that step, I try to clean the graft all the way that I can of the tenon to make a thinner graft. A thinner graft, it will make a better adhesion of the graft, and minus tenon, I think is minus possibility of rejection or coming back. I will very thin to the limbus, to the Vogt and palisade. There's a technique I use. It's a shape of the tenon, and go all the way to the stem cells, because I think that's the most important part of this surgery. So we go all the way through the stem cells. This shaving is to clean up the tenon. We can do it repetitive times until we only get the conjunctiva and stem cells in that plasty. It's not necessary to cauterize this zone, but that's the Vogt and palisade we want. Then we can cut the tenon is surrounding the plastia, so we can have a very aesthetic graft. No? We do some traction of the graft and then cut very near to the limbus. This technique is with glue. It's a glue made with coagulation factors. There's factors of coagulation and the activator, and then we only approach the graft to the niche. If we don't have the glue, we should only start suturing. I do 1 or 2 sutures, episcleral ones, to get a very tight and firmness of the graft, and then the others could be only conjunctivals. We try to put the graft like more 1 or 1.5 millimeter from the limbus, not too tight.
So not on the cornea, so back from the cornea by about 1.
1 or 2 millimeters.
Your thinking is that allows space for the stem cells to migrate across? Is that your thinking?
Yes. I think that's the best place to situate the graft, and it will help not to do a corneal dealing. No, it could be the graft rotate through the cornea, and then creates a dealing. I saw sometimes, so I prefer to leave a space for the stem cells to create a space and get away from dealing.
Okay, thank you. Also, you mentioned to me earlier about making some incisions in the graft. Can you tell me about why you do that?
Yes, mostly when you use some glue, it could be make the graft thinner. We talk about the we want a thinner graft, and if we use glue or we cannot take all the tenon, that's gonna make thicker, and it could have a corneal graft edema. So the the technique I use for that is with the same needle that I inject the anesthesia subconjunctival, I perform some perforations in the center of the graft, nothing less. 5 or 4 perforations, not too deep, and that's.
These are round perforations from a needle.
Yes, that takes off the graft's edema.
I see a number of different surgeries over the years, and some people will just put 4 sutures, one in each corner, put a square graft, and sometimes there are gaps between the graft and the original conjunctiva. How important is it to keep adding sutures to close up every single gap, or does it not matter?
I think that the sutures of leave the sclera open, that's what you're trying to say, it will not be dangerous at all, but as soon as we took all the tenon as possible. But if the tenon is down and we have a clear sclera, is a way a una recidivation, no? And could have granulomas. Too much traction could make lose the graft, and a postoperative with too much symptomatology. The patient start scratching, foreign body sensation. So I prefer to not leave it open at all. Try to close it. If you use 20 minutes more and put 4 or 5 sutures more, I think the results will be better for the patient. I prefer to perform the surgery and give corticoids post-operative. I use low penetrancy corticoids in lower doses. I use like 3 weeks of loteprednol or fluorometolone, and that's corticoids that we have here, and I give a therapy like 1 week every 4 hours, the next week every 6 hours, the next week every 8 hours, and then suspended. The first one is to take the pterygium with traction, not to cut it too much, because that's gonna leave a very smooth surface of the cornea and the limbus. Clean the cornea and the limbus well. Take your time if you do it with every instrument you have, but I like to match the use of the knife, the round knife, because the form of the knife. That's a good secret, I think. The graft technique to clean it well, take all the tenon you can, and go all the way to the stem cells. That's the secret, I think, for this surgery. Other tip that I use is to perform the perforations of the graft, and basically you will know after the first or second week that has the regression of the pterygium. So talk with the patient a lot, no? Explain the things that the patients have to do to take care of that surgery.
Thank you. That's really wonderful. I really appreciate your time. It's been really valuable. Thank you.
No, it's a pleasure for me. Thank you.